Today our tutorial about anaphylaxis is very high yield module. Many of examination board pick up some question from this module. Again, we are going to cover only high yield points, not everything that we learn in the college. Okay. Anaphylaxis. It's a severe life-threatening generalized systemic hypersensitivity reaction characterized by rapidly developing life-threatening airway, breathing, or circulation problem, usually associated with skin and mucosal changes. So let's focus on very important point of anaphylaxis. Number one is rapidly developing. So I give the number one, okay? And another thing you will find in that patient with anaphylaxis reaction, systemic compromise, for example, hypertension, worse of wise, difficulty in talking, etc. The last one you will find may patient develop rashes, skin rashes, or lip swelling, fascia swelling. So these are skin changes. So any patient with following feature would be considered patient suffering with anaphylaxis reaction. However, if patient has only skin changes, for example, a rash or lip swelling or fascia swelling, but not systematically compromised, for example, no hypertension, no horse of voice, respiratory rate is normal, saturation is normal, and it's not rapidly developing, then you may think other allergic reaction, not anaphylaxis. For example, angioedema, patient may suffer with angioedema or may suffer with urticaria, but not anaphylaxis. Okay, let's move on. Signs and symptoms of mild or moderate reaction accompanied by one of the following features. Sign: wheezing you will find in patient, or persistent cough, swelling of the tongue you will find, decreased level of consciousness. These are relevant to respiratory, difficulty talking hoarse voice as well. syncope or dissonance due to hypertension, pale or floppy due to vascular compromise as the anaphylaxis reaction, the vascular permeability increase due to degranulation of mast cells. Abdominal pain, you will find GI compromise in the patient as well. So one more question I just want to highlight. If any patient presented with skin rashes and angioedema, but he has abdominal pain or GI compromise, it's also considered as anaphylaxis reaction, okay? Just simply skin changes or mucosa changes, for example, swelling or rashes, not considered as anaphylaxis, okay? So alone, these are not enough to make diagnosis anaphylaxis reaction. This is face. You can see the facial swelling in this patient, and here lip swelling, skin rash, etc. Okay, let's move on. Causes and medication, or the most common antibiotic, which is called penicillin, is most common cause. NSAID second, aspirin, ACE inhibitor, most commonly in older age. Anesthetic agent, for example, muscular relaxant and contrast media. So these are the medication which are involved in anaphylaxis reaction. Others, food allergy, very common in children. Nut allergy, especially seafood, most common in also in children. Insect sting for all ages. Latex can be possible. Idiopathic and C1 esterase, etc. These are other causes of anaphylaxis reaction. Okay, let's move. Management. We have initial steps, so we have to follow that. First, we have to call for the help, lay the patient flat, and raise the patient legs. Now, the question might arise, why do we do that? We do that because it will increase the venous return to the heart, and eventually it will increase the cardiac output. As you know that in anaphylaxis reaction, patient is compromised systematically. It will increase the vascular permeability, will lead to a decrease in blood pressure. So when you raise the patient's legs up, it will increase the venous return. Eventually, it will increase the cardiac output. As a result of that, you will find the patient blood pressure will be rise. So that's why we have to follow this system. And this system most commonly used in outside of the hospital setting. For example, restaurant patient develop anaphylaxis reaction. What is your immediate next step? If they give you the option is raise the patient legs up, and number 2 is adrenaline IM, so you have to choose to raise the patient legs up first, or the position of the patient, not adrenaline IM. Then you go for adrenaline IM, okay? But usually, if they ask you the question about the pharmacological treatment, if they give you a scenario and they ask you which of the following is next appropriate treatment, for example, they give the drugs, A, adrenaline IM, B, oxygen, C, for example, adrenaline infusion. In this situation, you have to choose adrenaline IM. Even we have to give first and then the oxygen therapy. As you know that the patient lungs doesn't have an issue, actually airway tract has the issue due to bronchospasm. This all going to happen. And so what we have to, we relieve the bronchospasm. We use the adrenaline which act on the beta 2 agonist receptor, which will relax the bronchi muscles. Eventually, it increase oxygen flow to the lungs. It means not airway tract will be wide, not narrow. So this is how it is. So what we have to do, and more, it will also act on alpha receptor to contract the vascular system, for example, vessels, and eventually it will increase the cardiac venous return and cardiac output. So adrenaline, very important drug to relieve all systemic compromise symptoms and signs, for example, airway, and also the hypertension due to increasing vascular permeability. So what we have to do is reliable as we have to give adrenaline first, then we have to follow other supporting measure. And I'm going to show you next. So there is a doses for adrenaline. For adults, we have used 500 mcg microgram or 0.5 ml. For children greater than 12, for 500. So what the dose is going to be half of after 6 to 12 year age. If we go down further, 6 to 12, 300, and 6 to 6 years further half, 150, less than 6 months going to be 150 or 100. Okay, other supportive measures, you have to establish airway if necessarily and apply the high flow oxygen. So again, if we talk about the drug treatment, oxygen is also used as a drug. So in this situation, we go adrenaline IM. It will relieve all the symptoms. So adrenaline is the first line treatment for anaphylaxis, not the oxygen. Okay, burn your mind that. Apply appropriate monitoring, blood pressure, pulse oximetry, and ECG, etc. Fluids, give the crystalline fluids bolus, adult 500 to 1000 ml into IV, and children 10 ml per kg in IV. Okay, let's move on. Now we're going to focus on refractory anaphylaxis. Definition: refractory anaphylaxis is defined as anaphylaxis requiring ongoing treatment due to persisting respiratory or severe symptoms despite 2 appropriate doses of IM adrenaline. It means that the persistence of anaphylaxis despite 2 doses of adrenaline will be considered as refractory anaphylaxis. Okay, this is very simple. Management. There is some modification to refractory anaphylaxis if we compare with the previous one. First, you have to seek expert help because this patient not responding to IM adrenaline, 2 doses. Okay, set IV adrenaline infusion. As in previous slide, we learned that we have to give adrenaline IM. Okay, at least 2 doses. If not responding, then we consider that reaction as a refractory anaphylaxis, and the treatment will be modified. So adrenaline again is the first line, but we will set IV adrenaline infusion, okay, not IM, and can be given IV or IO until the central venous access obtained. Where this protocol isn't available, or patient being outside of the hospital setting, for example, paramedics is bring to the hospital. In this situation, you have to continue to repeat IM adrenaline after a 5 minutes interval until the infusion has been started. So normally we give 2 doses of IM adrenaline, then we start the IV adrenaline in infusion form. But if patient is outside of hospital setting or the hospital which doesn't have this protocol, in this situation, you have to continue to give IM adrenaline every 5 minutes interval. Okay, how to make it: mix 1 mg or adrenaline to 100 ml of 0.9% sodium chloride or 1 ml of 1 mg per ml. Okay, and connect using an infusion pump via dedicated line. Start at the 0.5 to 1 ml per kg per hour rate, depending on severity in both children and adult. If it's moderate, you can start from 0.5, but if it's severe, then you have to start from 1 ml per kg per hour rate. Next is continuous monitoring, ECG, BP, pulse oximeter every 5 minutes, because you give the adrenaline, so there maybe can be BP can be rise, there can be ECG changes, there can be heart rate increase. Okay. Next is other supportive measures you have to take. Severe airway obstruction is uncommon in refractory anaphylaxis. If tracheal intubation indicated, for example, is severe, then performed by experts, and follow the difficult airway protocol. We will discuss in separate module about difficult airway protocol. Okay, circulation, a large volume for this refractory needed. As previous slide, we learned that we may give 500 bolus, or in children maybe 10 ml per kg bolus. So here is different situation. We may give 3 to 4 liter in adult. May be needed for severe anaphylactic shock. Consider Hartmann or plasma light rather than 0.5 sodium chloride normal saline to reduce the risk of hyperchloremia. So it's very common if you get large amount of sodium chloride, or you can say normal saline, there is high risk of developing of hyperchloremia. So we have to avoid this risk, so we can use Hartmann or plasma light. Okay, But anyway, there is no contraindication to normal saline. Last one is consider vasopressor as the second line treatment. Okay, such as for example noradrenaline. Let's move on next. We're going to focus on biphasic reaction. Definition: anaphylaxis can appear to resolve, but then cause a recurrence of the symptoms several hours later in the absence of further allergen exposure. It means that the relapse of the symptoms or relapse of the shock after improve. Okay, that's called biphasic reaction. This is known as biphasic reaction and occur in 5% of patients. Okay, after improvement, then further again develop the symptoms or even severe will be considered a biphasic reaction. Risk factor for biphasic reaction: more severe initial presentation of anaphylaxis, initial reaction requiring more than one dose of adrenaline, delay in adrenaline administration, not delay in the present to emergency, actually delay in adrenaline administration greater than 30 to 60 minutes from symptoms onset. So these are the risk factor for the biphasic reaction, or these are the predictor for the biphasic reaction. Okay, so I had mnemonic SMD. Okay, for that, easy to memorize these risk. SMD, S means severe initial presentation. MD is more than one dose of adrenaline. D is delay in adrenaline administration. It depends. If you make better mnemonics, you have to follow that. Okay, let's move. Key points. Anaphylaxis likely when three criteria match, as I described early in the first slide. First, acute onset of illness with sudden progression. As I said, it's very rapid to develop. 2, life-threatening airway, breathing, or circulation problem. That means systemic compromise. Okay, number 2. Possible skin or mucosa changes, although these may be absent and not required for diagnosis. As I said, if the patient only present with the mucosa changes, or for example, angioedema or rash, it will not consider as anaphylaxis unless the patient also have other symptoms, for example, systemic compromise, hypertension, esophagus, talking difficulties. So a patient has about 2 and not this one, the third one, is still considered as anaphylaxis. Okay, there is no role of antihistamine, however it may elevate the cutaneous symptoms. For that I already put in the next slide the doses of antihistamine. The routine use of corticosteroids to treat anaphylaxis is not an advice if the patient is suffering from ongoing asthma, so maybe you can consider. Use of glucagon in patients who are taking beta blocker may be resistant to therapeutic effects of adrenaline. This is how it happens in bradycardia. When we treat the patient with the beta blocker in bradycardia, we start IV adrenaline infusion. Okay, adrenaline infusion. So as you know that the beta blocker are competitive inhibitor. So what if we give the adrenaline? It will also compete with beta blocker on that receptors. So if the dose means quantity of adrenaline will increase, obviously it will take over on the beta blocker. So this is what we do in bradycardia, but in anaphylaxis, as you know that we give adrenaline IM, not IV. Okay, so in this situation, this is not enough. So it would be better we use a glucagon to counter the beta blocker effect. Okay, so this is how, if the question came in the exam about relevant to patient is taking beta blocker, now he developed anaphylactic reaction, then boom, you have to go for glucagon. But if the patient, if the question relevant to bradycardia, and they said patient has developed type 2, Mobius type 2 heart block, and patient is taking beta blocker, in this situation, you have, if there is option IV in adrenaline infusion, that you have to choose that, not the glucagon. If the question said a patient is resistant to that adrenaline, it's still, then maybe you choose the glucagon, but still the glucagon adrenaline infusion is better choice for bradycardia. Okay. Adrenaline can give a second dose if the reaction persists after 5 minutes. Okay, after 2 doses of adrenaline, adrenaline infusion should be started. Okay, like if in case, as I said earlier, if a hospital doesn't have protocol, maybe you can continue further doses interval of 5 minutes, but the protocol is normally we follow adrenaline infusion after 2 doses of IM adrenaline. Let's move on. Next is NICE recommends 6-hour observation. Those patients who has 2 doses of IM adrenaline or previous biphasic reaction. So 6 hours for monitoring for those patients. And 12-hour observation, those patients who has recorded more than 2 doses of adrenaline, has severe asthma, or their reaction has been low and severe respiratory compromise. Investigation Research Council recommend 3 tryptase level. First, a resuscitation started, second, 1 to 2 hours after substance started, third, and 24 hours later. Now it's very important, anaphylactoid versus anaphylaxis. So we have to find the difference. Anaphylactoid reaction, first time exposure to allergen. Any patient first time exposed to allergen and then develop a reaction, it would be considered as anaphylactoid reaction, and it will be non-immune mediated. But the same patient, if second time exposed to that allergen, for example, he took the nut again and he built up, developed a reaction, it will be called anaphylaxis reaction. And as I mentioned here, on further exposure to allergen, the responsible allergen antigen bind to antigen specific IgE antibodies, leading to mast cell degranulation. Histamine and other mediator will be released. So it means that it will be immune mediated. So in summary, anaphylactoid, first exposure, and non-immune mediated. The same patient and with the same allergen, if second time exposed or further allergen to previous, means it will be immune mediated, and this reaction will be considered as anaphylaxis. In other words, we can say in anaphylaxis reaction, patient will have previous history of exposure to that allergen. Okay, in other words, let's move on. Key table, this is a table taken from Ockham syllabus. It's very important. Let's focus: food allergy, medication, venom, sting, etc. Most common in children, food is allergy, most common in children, less common in older adults. Typical presentation will be breathing problem. Onset will be less rapid if we compare with the drugs or other. History of asthma is very common. This is a very important point, that the patient who has a food allergy, most commonly they will also have asthma or atopy. Okay, but those patients with the medication allergy, the asthma is uncommon and also in a sting. Okay, this is a very important point. So we have the recall, and we make that made relevant to that table. Okay, so the anaphylaxis reaction will be very severe in those patients who has asthma, food allergy, and also asthma. Let's move on. This is about the doses of antihistamine. I believe that's not very difficult, but it's very hard to say. It will come in the exam. The frequency of food sensitization in asthmatic children is higher than the expected in general population. That's the reason it has been found that the asthma is a risk factor for severe or fatal anaphylactic reaction. Okay, let's move on. It's very simple. NICE recommendation prior to discharge, so we have to follow this guideline before we discharge the patient. So it says the healthcare professional should offer patient information about anaphylaxis, including signs and symptoms, to their carer or the parents, information about the risk of biphasic reaction, information what to do if anaphylaxis occurs. For example, you have to help them or to demonstrate them the use of the adrenaline, and prescription of adrenaline auto-injector and their demonstration, correct use. And next is, in the last one, is prescription for two should given rather than single auto-injector. Next is 3 types of commercially available EpiPen, etc. There are other Jackson, and they come in 0.3 ml or 0.15 ml strength. So you have to demonstrate them how to use them, okay? And this is about the nice recommendation.